Good evening. My name is Dr. David Doman, and welcome to another edition of Housecall. What's new with lung cancer, both in terms of diagnostic testing and new treatment options? Find out more right now. My guest this evening is Dr. Puja Khaitan, a noted surgeon from MedStar Montgomery General Hospital. Puja, welcome to Housecall.
Thank you. Thanks for having me, Dr. Doman. It's a pleasure to be here.
Great. So briefly tell our viewers about your professional background.
So I'm a thoracic surgeon. I'm a non-cardiac thoracic surgeon. What that means is I primarily operate in the chest, but not related to the heart. The most common pathology that we deal with is lung cancer.
Okay. And tell us about your training.
So I've done my general surgery training at Emory University, and I followed by some research that I conducted at MD Anderson Cancer Center. Then I completed my cardiothoracic training at Brigham and Women's Hospital in Boston.
Very nice. And your practice is limited to the hospital center, is that correct?
So I primarily operate at MedStar Washington Hospital Center, but I do have privileges to operate at Georgetown University, and then I'm privileged to have patients that I can see at Montgomery Medical Center, as well as MedStar Southern Maryland and Reston Hospital.
Very nice. So the topic for this evening is lung cancer. How common is lung cancer in the United States at this point?
Lung cancer is actually quite prevalent, almost being the second or the third most common malignancy in the United States of America that leads to cancer-related death. As we know, lots of treatment has gone on for colon cancer, breast cancer, but very little has been done for lung cancer. Things are changing rapidly, so we're hoping that lung cancer will have a better and brighter future.
In terms of lung cancer, what is the danger of lung cancer if somebody develops it?
So usually lung cancer will start off with having lung nodules, and when the lung nodules are very small in size and they start to become larger, people may not have any symptoms at first. So for the most part, lung cancer can get picked up incidentally if you're getting a CT scan, say for abdominal pain or chest pain that's of cardiac origin, and then lo and behold, you get an incidental lung nodule diagnosed that once gets picked up, you realize that this is lung cancer. Unfortunately, most patients present with advanced stage lung cancer, and if you're presenting with symptoms such as chest pain or shortness of breath, or what they say, fluid on your lungs, usually that means it's an advanced stage and very little can be done from a surgical perspective. And usually at that point, patients are turned over to the oncologist.
What is the difference in outlook of patients having a lung cancer picked up when it's just a tiny nodule, the size of, let's say, a pea or a marble, as opposed to a full-blown tumor in the lungs?
That's a great question. So when lung nodule gets picked up as a smaller nodule, which is 1 or 2 centimeters in size, usually it has not spread anywhere and it's limited and confined to the lung. When it travels, lung cancer travels by lymphatics. So it first goes to lymph nodes and then travels to the rest of your body, such as the brain, bone, or liver. When it's early stage and it's only limited to the lung, that's stage 1 or stage 2 cancer, usually those can be operated on and removed, which is the standard of care. But when the cat's already out of the bag and you have lymph node involvement, then the up stages you to stage 3 or even 4. And by that point, you usually are unable to offer significant amount of tumor burden resection. And so at that point, you say, well, you're not a candidate for surgery and I would have to commit you for chemotherapy and radiation.
So when they've already gone to stage 3 or 4, that means the cancer is spread elsewhere in the body.
Right, either into the middle of the chest, which is called the mediastinum, or somewhere else in your body.
Such as the liver, I would imagine.
Yes, absolutely right.
Yeah. So you've alluded to the symptoms of lung cancer. So what are some of those symptoms that should alert our viewers that these are things they don't want to ignore?
So most patients present with very vague symptoms such as fever, chills, night sweats, or weight loss. Unintentional weight loss is very concerning, and it can be a sign of any hidden malignancy in your body. However, symptoms that are very pertinent to the lungs, such as chest pain, cough, shortness of breath, coughing with blood, are very, very concerning signs for tumor that may be involved in the lungs.
And when somebody coughs up blood, does it mean automatically they have cancer, or could it be something else?
No, people with bronchitis can also present with hemoptysis, meaning blood in cough. If your cough in your blood has a little bit of blood tinge to it, usually don't worry. Most PCP doctors or urgent care doctors will prescribe you some antibiotics and see if that resolves. However, if that persists and you still have repeated coughing episodes and spells where you have some blood in it, you must follow up with an X-ray or CAT scan and even be referred to a pulmonologist at the very least.
So what are some of the reasons people develop lung cancer if it's so common?
Unfortunately, whether you're a smoker or non-smoker doesn't prevent you from developing lung cancer. In the United States alone, there's almost up to 20% chance that you may develop lung cancer having not smoked a single cigarette in the day. And usually the reason why people develop lung cancer in that cohort is because they have some sort of genetic mutation that predisposes them to develop lung cancer. It happens more often in females that are of Asian origin in their mid-40s or so. But why that is the case, we don't know. Now, the prognosis of that group of patients who are never smokers is much better. We know that there's a risk of having smoking or secondhand smoking that predisposes to a very elevated risk of developing lung cancer. And that's secondary to severe inflammation and damage to your lung parenchyma, lung tissue.
Besides genetics and smoking, what are some other risk factors for lung cancer?
Unfortunately, all the lung inhalants that we inhale in every day, including pollution, radon, that also predisposes you to lung cancer. We think a lot of our community and young people in the youth community think that vaping is a safer product than smoking, but it actually is not. The other product that people don't associate with lung cancer is cigars. Believe it or not, one cigar is equal to 6 cigarettes. So if you're smoking 2 or 3 cigars, you've smoked at least a pack of cigarettes in that one day.
How important do you think it is that everyone should have their homes screened for radon?
I think that's definitely a health risk. I'm not sure if I would say that everybody should be screened, but I believe that radon does have you predispose you to a very elevated risk of developing cancer. And if you or your neighborhood is prone to having high intensity of radon present, you should have that looked at and reported to your local authorities so it can protect the local population as well.
You mentioned the recent observations about genetic risk of developing lung cancer without any other associated risk factors. And you mentioned particularly in Asian women. Does that mean that you can have family histories of lung cancer without any other risk factor?
Yes, absolutely you can. However, we have not been able to detect that just because, say, your mother had lung cancer and she had this mutation, which is the EGFR, epidermal growth factor receptor mutation, doesn't mean that you go get tested and you would also have an EGFR receptor mutation. And the reason is because it's very confined to the cancer tissue itself. It's not a marker that you can find in your blood work or in your other normal tissues. It's usually a mutation that happened in that lung tissue itself, which then became abnormal, grew into a number of cells and actually formed a solid tumor in your lung.
Well, by now, I think you've made the compelling case that our viewers certainly want to do everything they can to avoid developing lung cancer. So what things would you suggest they do in terms of their lifestyle to avoid cancer risk?
So the one thing that people should do is, if you are smoking, quit smoking immediately. There are a lot of smoking cessation tools that you can employ. You can ask your primary care doctor or be referred to a pulmonologist so that you can increase your chances of quitting smoking. If you live with a person who smokes or has secondary smoking exposure, you should limit that, as well as try to be healthy, try to exercise, do things that are better for your lung function overall that would help you prevent the chances of developing lung cancer. There is an entity of COPD and emphysema that you can have lung damage even when you're not a smoker, that puts you at higher risk for developing lung cancer. And if in case you have that, you should and must be screened and be evaluated by a pulmonologist.
You mentioned exercise and eating healthy, which of course is good for general health, but is there any data that shows that exercise and eating healthy specifically lowers the risk of lung cancer, or is it more for general health?
No, it's more for general health. It's to make sure that if you were to develop any symptoms and you were to undergo any sort of workup, your lung function would be ideal and suitable to be able to tolerate and withstand the insult. There is no direct correlation or data that shows that that itself protects you to developing lung cancer. It's general things being general. If you take care of your health and you are more vigilant about exercising, eating properly, most likely you will follow up with a medical professional if you were to get sick. So it just puts you in the right and best shape to make sure that you are keenly aware of the things that are going on with your body. And if something goes aberrant, you follow it up.
Is there any evidence that this is occupationally related? For example, firemen, people who work in factories, miners, etc.
Great question. I don't know a number or proportion on top of my head, but yes, there is a very high risk associated with certain professions where people tend to develop lung cancer, and even their family members. The simple mere fact that you bring home the clothes that you wear at work and all the particles and the inhalants and contaminants with you at home, you expose your family members to it. For instance, as you know, asbestos is associated or can be linked with lung cancer or another pleural malignancy, another lung lining malignancy. And the reason is because people can have those particles stuck to their clothes and they can bring them home and expose the rest of the family.
Is there any sort of occupational health recommendations that are made to those sort of workplaces?
Yes. So people who work in places where they strip down buildings, especially old buildings that may have asbestos laid in it, coal and mine workers, they should at all times wear N95 masks so that they can prevent any inhalation. And there are guidelines that are built by the USPS task force that suggest that people who work in those professions should and must change their clothing, perhaps even take precautions before coming home so that they don't expose the rest of the population to the inhalant products that they've been exposed to at work.
Excellent advice. We're going to pause briefly for a public service announcement. More with lung cancer specialist, Dr. Puja Khaitan, in a moment. Don't go away. We'll be right back.
You quit smoking and thought, that's that. But here's the thing about lung cancer. By the time you see the symptoms, it could be too late. But now, there's a new scan that can detect lung cancer early when it's more curable. If you smoked, get scanned. Talk to your doctor or learn more at savedbythescan.org.
We're back. Our topic tonight is the latest advances in diagnosis and treatment for lung cancer. My guest is Dr. Puja Khaitan of the MedStar Washington Hospital Center. Puja, when we paused for the break, we were positioned now to discuss specifically the different diagnostic opportunities to pick up lung cancer. So tell us, what are some of the different diagnostic tests that you have at your disposal?
So chest X-ray is actually not the best modality to pick up lung cancer. Nowadays, there's a new tool that we have utilized to diagnose lung cancer at an early stage, which is the lung cancer screening low-dose CT scan. The reason why it's called that is because you get exposed to a lower dose of radiation, where you make thicker cuts of the lung and you are able to pick up some abnormality. Now, if you do find a lung nodule on somebody on a low-dose CT scan, you typically follow that up with a higher resolution CT scan, where you get thinner cuts of this chest to be able to make sure that you have evaluated every area of the lung and made sure you did not miss any other lung nodule.
What kind of patients should receive a low-dose CT scan for screening or evaluation?
So there's a certain criteria that the USPS task force has put up. It has recently changed as of March of this year and have expanded their criteria. So anybody who's at risk of developing lung cancer, for instance, if you're in the ages of 50 to 80, you have a 20-pack year smoking history, which means you will take the number of packs of smoking cigarettes that you've smoked times the number of years. So say you smoked a pack a day for 20 years, that's 20-pack year, or 2 packs per day for 10 years, that's 20-pack years. And the fact that if you're currently a smoker or have quit within the last 15 years, you qualify for this CT scan because your risk of cancer is for developing lung cancer is so high. You qualify for this low-dose CT screening exam.
You mentioned pack years. Is there any evidence that, let's say, 20 pack years is less risky than 40 pack years? Or is there a certain critical point where it doesn't really matter?
No, unfortunately, there's no hard number. As you all must have heard of cases where you may not have smoked a whole lot of cigarettes and you develop lung cancer. And then there are patients who smoke cigarettes all their life, they don't develop lung cancer. So unfortunately, while there is no clear-cut number where you can say, okay, I've smoked this much and maybe I should stop smoking at this point so I don't develop lung cancer, there's really not that cutoff number. But we simply, because there is a high chance that you may develop lung cancer because you're a smoker, which is why the recommendations have been put in place.
If a patient meets the criteria spelled out by the U.S. Public Health Service, how often should somebody get a low-dose CT scan for screening purposes?
So if you fall within those guidelines, if you have only quit smoking in the last 15 years, you would qualify to get a low-dose CT scan every year. Now, if you don't have anything detected on the low-dose CT scan, they will space it out to every year. But if you get a low-dose CT scan and there's something abnormal, you will be followed up closely. There are certain criteria. We look at the size of the nodule, the suspicion based on your smoking history, any lung cancer history within the family, or your personal history of having underlying pulmonary or lung disease, such as COPD and emphysema that I mentioned before, will predispose you to an elevated level of risk of developing cancer. In those cases, the clinicians will typically screen you sooner, not wait for the entire year.
So let's talk through this process then. A patient who's a high risk, 20 pack years, let's say, no symptoms, and they get a low-dose CT that shows a suspicious nodule. You then go on, as you said earlier, and get maybe a follow-up CT with better definition of the nodule, and you decide this is a potential malignancy. What's the next step?
So in that case, as most physicians, if you're being seen by a primary care doctor, they will refer you to either a pulmonologist or a thoracic surgeon, such as myself. And depending on the size of the nodule, the appearance of the nodule, whether it has spiculations and arms, where it sits, how exactly it sits between the lung as well as the chest wall or next to a blood vessel. People will then discuss whether or not this is suspicious enough and we should get a PET scan or a biopsy or both, because you need to make a diagnosis.
And explain to our viewers what exactly is a PET scan and how does that contribute new information in addition to the prior CT scan?
A PET scan is a positron emission tomography. I realize that's a mouthful. But a PET scan is done when we think that there may be a malignancy. And basically, it's a radio-labeled sugar scan where radio-labeled sugar is injected in your IV, in your vein, and it goes into your bloodstream. And anything that eats up sugar should light up. Now, in that sense, things that are eating up sugar at a very high rate, such as your heart or your brain, they will also light up. But the idea is that because cancer cells tend to eat up a lot of sugar, they will light up on a PET scan. It's a whole body PET scan, so it examines everything starting from your head down to their mid-thigh level. And if anything is abnormal in a lung nodule that could be malignant, if it has gone elsewhere in your body, typically in an ideal setting, the PET should pick that.
So the PET scan is done and it lights up the lung nodule only. What's your next step?
Then you should also ask yourself whether or not you think that this could be infectious in origin, whether it could be cancer in origin. If a person has high level of risk, including cigarettes and cigar smoking, and you think that this looks and smells like cancer, then we typically recommend either doing a biopsy, which can be done two ways. You can have a radiologist stick a needle in your chest and get a piece of that tissue and see if that's cancer or not. Or nowadays, we can do this endobronchially, meaning we can go inside your airway while you're asleep and using a certain map where from the CT scan, we can guide and make a pathway to your lung nodule so a needle can pass into your chest and we can biopsy that nodule and then decipher on pathology whether that's cancer or not.
And if cancer is confirmed, what's your next step?
Then depending on the size of the nodule, we can decide whether it's a small nodule, nothing else lights up in the middle of the chest, suggesting that there's no involvement on the lymph nodes. We talk about surgery. Surgery comes in many shapes and forms. There's a certain amount of workup we have to do for the patients, including some lung testing and heart testing before we talk about surgery. And the reason is, you never want to operate on a patient and then have decline of their quality of life. So you want to make sure that their lung function is strong enough that they can withstand surgery. It all comes back to that point I made earlier, that you should be healthy and active, because if your lung function is in good shape, you can tolerate the surgery, which is the standard of care. Who wants to have cancer left behind in their chest? So if we can operate on you, we would do this lung function testing, determine that after the surgery, your lung function will be appropriate so you don't get dependent on oxygen for the rest of your life. And in those cases, we will offer what's called an anatomic lung resection, meaning we remove that lung or that part of the lung which has the tumor, as well as the lymph nodes that drain it, to make sure that no cancer has gone out of the lung itself.
When you pick up a nodule at an early stage, and then you ultimately operate, and it appears to be confined to the lung, is it fair to say that you cured the patient of lung cancer?
Unfortunately, we never use the words cured. We tell patients that cancer is extremely smart. It can always come back. If you continue to smoke, the risk of developing a second cancer is extremely high. If you were in that window of quitting smoking in the past 15 years, having that 20-pack year history, and you came to the route of the lung cancer screening, well, you're still at risk of developing a second cancer. So what we typically do, even for stage 1 lung cancer, according to the NCCN guidelines, we still continue doing surveillance scans on a patient every 6 months at the minimum for the first 2 years, and then every year for the next 3 years up to the 5-year mark. The risk of malignancy, recurrent malignancy at 5 years drops down significantly, which is why the recommendations stop at 5 years. However, we do see patients developing lung cancer even further down. Those are few and far between, and that's why those rules are not generalizable to all the patients.
If somebody does develop a cancer, let's say 6 or 7 years post-op, do you think it's a recurrence of the original cancer, or is it rather a concurrent cancer that's developed because of the same risk factors?
That's a great question. Unfortunately, nobody knows. We do like to give patients the benefit of the doubt and say most likely it is a second primary malignancy. So what that means is somebody having two nodules present at the same time on two different sides upstages a person. That's a stage, maybe a stage 4 cancer. We don't know 100%. We have to do some more testing to determine if these are two same types of cancer. Do they have the same types of markers in them? Or it would be nice to say that this patient unfortunately has two primary malignancies. Two primary malignancies are better than having one stage 4 cancer. Sort of contrary to what most general population think. Why would I want two different types of cancer at the same time than to have one cancer that's spread? Because that upstages you if your cancer spreads. So it's always preferred to have two stage 1 cancers than to have one stage 4 cancer.
There's been a lot of interest in so-called liquid biopsies, doing blood tests to look for microscopic cancer cells in the bloodstream to do a non-invasive diagnosis of a variety of cancers. Is there any interest in your specialty with that particular technology?
Absolutely. So circulating tumor cells has been a very hot subject to discuss in lung cancer. There is a very booming, rapid growth of literature investigating, diagnosing circulating tumor cells and seeing if patients can be picked up to develop malignancies, and especially recurrent malignancy. Unfortunately, nothing has panned out yet to be able to clinically apply.
So besides surgery, if somebody unfortunately is found during their evaluation to have a more advanced cancer, what are some of the other treatment options available for these patients?
Yes. So if a tumor has spread to the lymph nodes, we typically will discuss these patients at a multidisciplinary tumor boards. Most big, large institutions where there is a cancer institute will have a group of multidisciplinary clinicians come together, which usually comprise of surgeons, pulmonologists, radiologists, medical oncologists, radiation oncologists, pathologists, to discuss complicated cases. So a patient who has cancer that's spread out of the lung into their lymph nodes, we would typically discuss and present and see if there's anything that can be done to downstage the tumor. And if they can be downstage, that means that they have good biology. What I mean by that is that there are patients. What I mean by that, if there are two patients who are diagnosed with the same type of lung cancer, one lung cancer can be extremely aggressive, and if you repeated a CAT scan on them in 6 months, they may be double in the size. However, another patient, if you repeated a scan in 6 years, they may not have hardly grown. Are they both the same type of cancer? Yes, but one has a very aggressive biology of the tumor and the other does not. So if a person comes with a tumor where the lymph nodes are involved, we try to treat them with upfront chemotherapy and or radiation to see if we can downstage them. If you are able to downstage them or at least control their tumor, that patient has good biology and you could potentially offer them surgery. However, if a patient gets treated with chemotherapy and the tumor grows beyond chemotherapy and starts to spread in other places, that's usually pretty aggressive biology, and no surgery would benefit that patient's survival. So it's very selective. It's what we call personalized medicine. So you have to personalize the therapy and tailor it to the patient for their appropriate pathology.
Excellent. Well, we are out of time. Thank you so much for joining us and providing all this important information. My thanks to my team at the studio for making this program happen. And my thanks to you, the viewer, for joining us this evening. Tell us how we're doing. You can reach me at my practice website, montgomerygastro.com. As for our next show, it's going to be a very important one. Amar Tobin, who is a well-known trainer for cardiopulmonary resuscitation and other healthcare emergencies, will be joining us. We'll be discussing an update in CPR that could be done at work or at home for an emergency. updates on drowning management, updates on a child who was found unresponsive, and finally, what to do in the face of your finding yourself in the middle of a mass shooting. What can you do to protect yourself? Clearly important issues. See you then next time for another edition of Housecall. Good evening.